Good morning everyone and welcome to EDU645 Adult Learning in Education and Work. My name is Vignesh and today I will be presenting to you a training needs analysis. This is part 2 of assignment 1, which is aimed at identifying a training needs analysis specific to either our workplace or educational institution. The first part being a written assignment and the second part being this presentation. So let's begin. What is a training needs analysis? A training needs analysis is the process of identifying gaps in the professional training and development needs of an individual or an organisation, and it aims to structure a relevant training program to bridge these gaps. This assessment, it considers the existing knowledge and skills of the learner by collecting and analysing current data on the scope of development available for the learner. In healthcare, we use training needs analysis to upskill staff to ensure that current and competent care is being provided to patients, which is in accordance with best practice as outlined by the Nursing and Midwifery Board of Australia. With this training needs analysis, I have linked it to the adult learning theory of constructivism. There are 4 types of adult learning theories, but the one that I have chosen is constructivism. Now in midwifery, we sort of engage in all the 4 learning theories, but in this assignment and this training program that we're potentially thinking of launching, it is in line with the theories of constructivism that outlines the need for interaction and engagement with your peers and learning that is facilitated through sharing lived experiences of your peers. The training needs analysis that we have decided to talk about is the administration of sterile water injection in the lower back of women in labour. This training needs analysis was based on the interview that I had done with 4 midwives at Fiona Stanley Hospital, which is where I work. These midwives are part of the Family Birthing Centre, which is a new model of care that has been launched by Fiona Stanley Hospital. Through interviewing these midwives, we learned that more and more women are asking for the option, having the option of sterile water injection in labour, but this is not yet an option at Fiona Stanley or, well, WA in general, because there are no policies and guidelines that have been outlined for it, and midwives have not been trained in the knowledge and evidence behind it. So that is why we are choosing to talk about this. Just to give you a little background on sterile water injections, approximately 30% of women in labour experience lower back pain, and this lower back pain is a result mostly from posterior labours where baby's back is against mum's back. They have lower back pain sometimes as a result of referred pain from the pelvis, and you know, due to movement in labour, all sorts of things. Sterile water injections are administered intradermally, and they are known to reduce lower back pain in labour. They are cost effective, they are safe, and it reduces the need for additional, well, it can reduce the need for pharmacological pain relief in labour. We will be talking about this further in the next couple of slides in detail. Why do midwives need to be trained in this skill? As I've mentioned earlier, there is an increasing demand from women who are starting to request sterile water injections in labour. This is an option that is available for women in Adelaide, in Sydney, in Queensland, but there is no current policy or guideline for the same in WA. There is a general lack of training and knowledge for midwives in the administration of sterile water injections, and a lot of midwives, in the studies that we've reviewed in the literature for this assignment, a lot of midwives state the lack of policies and guidelines actually affect their willingness to offer this to women in labour. Sterile water injections are actually an alternative. It's not a replacement, but it is an alternative analgesic option for women in labour that might not necessarily want to use pharmacological methods of pain relief as their first line of help, I suppose. It could potentially reduce the cascade of interventions associated with pharmacological analgesia, because we know that the administration of morphine and epidurals actually does reduce their mobility in labour, and the reduction of mobility in labour, as midwives and doctors know, does lead to obstetric intervention to facilitate labour progress. So besides it being a want as requested by women, it is also aimed at potentially reducing interventions for women in labour, which actually could increase maternal or it could promote better maternal outcomes for women and better satisfaction in labour as well. A background of sterile water injections. It focuses on the gate theory of pain, and as the illustration shows, it is administered subdermally at 4 points of the lower back. It gives almost immediate pain reduction in the lower back. The effects of sterile water injections can last up to 2 hours, and it can be repeated as many times as needed, which is very different to pharmacological pain relief options, which you can only give an X amount of morphine or an epidural to women in X amount of hours, which can be a bit limiting, but this can be repeated as many times as needed. It is safe because it does not cross the placental barrier, it does not cross over to the fetus. It does not affect maternal consciousness, unlike the epidural and the morphine, which actually does alter women's conscious states and makes them sleepy, drowsy, nauseous, all those sorts of things, which the sterile water injection does not do. It allows for mobilisation and keeping active in labour, which is fantastic because it means that it doesn't stall labour or it doesn't slow down the progress of labour, unlike other methods. It is cost effective because you're only using a couple of needles, a vial of water, which costs pretty much next to nothing, and it is a procedure that is initiated by midwives. You don't need anaesthetists present there, and as as midwives know, usually when a woman requests for pain relief, you do have to find a doctor to get the medication prescribed, and in the case of an epidural, you do need the doctor. Well, you need the anaesthetist there to administer it. So this is a completely midwife-initiated procedure. So it saves time for midwives and women in labour, and it is safe. The potential participants identified for the training program that we're thinking of rolling out are registered midwives that work all across the hospital. We are not extending this opportunity to students because you do need a level of training and accountability to be able to administer this injection. So it is just for midwives. The learning outcome that we are hopefully trying to gain is that midwives will be able to demonstrate and understand the correct procedure for administration of sterile water injections for women in labour to aid in the non-pharmacological relief of lower back pain in labour. The important thing to note is that it is not a replacement for other forms of pain relief. It is for women that do not want those sorts of those pharmacological methods of pain relief as their first line of call, but instead have the freedom to choose other sorts of pain relief before they resort to that. This training program will be providing necessary theory for the administration of sterile water injections. It will be assessing the midwife's ability to identify the points of injection and correct method of administration. We want to identify human error and reduce it in the sense that, you know, we want to make sure midwives are not injecting it wrongly, subcutaneously. It's intradermal, just on the surface of the skin, and not any deeper than that. We want to reinforce the need for midwives to provide evidence-based information to women to aid in their decision-making skills. We want to upskill midwives because as midwives who work in a hospital, we're always talking about upskilling midwives and giving them new information, new evidence, and, you know, encouraging them to maintain currency and competency in their care. It promotes collaborative working, and it involves sharing lived experiences of other midwives, and it encourages team-based learning. So what I talked about earlier about team-based learning is consistent with the learning theory of constructivism that we're looking at in this assignment, which we will talk about in more detail in the second assignment. The gaps and barriers identified for this sterile water injection administration is that there is a lack of policy and guideline for it. There is a lack of training and education. There is resistance from obstetric and multidisciplinary team because they haven't been offered the evidence that they've needed to be actually supportive of this. So we as part of the training, we are definitely going to be focusing on emphasizing that this is evidence-based. It is not something that someone created overnight. It has been used in other parts of the hospital as well for back pain, say for kidney stones and things like that. So it is definitely evidence-based. There's enough literature to prove that it works. And midwives also quoted heavy workloads and time constraints to be a barrier towards their learning, because most of us have patient load. We can't just abandon our patients and go off to teaching on some days when our workloads are heavy. So this is another barrier. So based on these gaps, I have arrived at a recommendation, and this recommendation will be further discussed in the second assignment, but in brief, we're thinking of developing a training program to upskill midwives in the administration of sterile water injections. It is using current evidence-based literature, and we will potentially be looking at devising policies and guidelines for the same as well. The training time we've decided should be cost effective, so we want to facilitate learning during double staff time, where we hand over, and then we've handed over, so the midwives that we've handed over to can care for our patients while we go off to learn. I was also thinking of introducing an e-learning, which helps with the time constraint part of it, and we're also going to be using the method of see one, do one, teach one, which is so this procedure is safe enough that it can be done in that way. We can see a midwife do it on a mannequin, we practice it on the mannequin, and then we've done it a couple of times, and then we can teach our colleagues the same skill. So yeah, these are the recommendations we've arrived on, which will be discussed in the second assignment. And that brings us to the end of the presentation. Thank you.